الفيرتشوال الاونلاين. ودلوقتي اللي هيكلمنا الاستاذ دكتور احمد خطاب. الاستاذ دكتور احمد خطاب ده Associate Professor of Pediatric Division of Pediatric and Endocrinology في Child Health Institute في نيوجيرسي، وهيكلمنا عن المانجمنت اوبشن in Pediatric and Adolescent Obesity.
Hello, everyone. My name is Ahmed Khattab. I'm an Associate Professor of Pediatrics in the Division of Pediatric Endocrinology at Rutgers-Robert Wood Johnson Medical School. And today I will be talking about the management options for pediatric and adolescent obesity. I do not have any conflicts of interest. Objectives for today's lecture include defining body mass index cutoffs, discussing the prevalence of obesity in the youth, discussing comorbid conditions associated with obesity, and some light on prevention, lifestyle modification, medication used for treatment of obesity, and bariatric surgical procedures. In children, a body mass index greater than the 85th percentile is consistent with being overweight, whereas a body mass index greater than or equal to the 95th percentile is consistent with obesity, and severe obesity is when the body mass index is more than 120% of that of the 95th percentile. In adults, 25 kilograms per meter squared body mass index is overweight. Obesity is greater than or equal to 30 kilograms per meter squared, and severe obesity is greater than or equal to 35 kilograms per meter squared. Although by definition, one would expect that only 5% of the population at a certain age group to fall above the 95th percentile, about 17% of the US children have a body mass index above the 95th percentile, making us think that the 95th percentile for body mass index is actually the 83rd percentile. Again, about a third of the US children are overweight or obese. In other words, they have a body mass index greater than the 85th percentile, making us think that the 85th percentile is actually the 67th percentile. Comorbid conditions associated with obesity include type 2 diabetes, disorders of lipid metabolism, a significant economic burden, hypertension, non-alcoholic fatty liver disease, reproductive disorders such as polycystic ovarian syndrome, pulmonary disorders such as obstructive sleep apnea, and last and not least, and not to be underestimated, the psychosocial burden associated with obesity. Poor self-esteem, stigma, and discrimination are well described with obesity. Depression is another major comorbid condition associated with obesity. Additionally, obesity may be predictive to bullying, where up to half of the obese children are victims of some sort of bullying. And it can go the other way also, where an obese child is 1.5 more times more likely to be the bully. Emotional functioning, social functioning, and school functioning is significantly lower among severely obese children. Studies have reported that the health-related quality of life in severely obese children was similar to those with cancer. Now, switching gears to type 2 diabetes and obesity, where type 2 diabetes and obesity in the youth versus adults has unique characteristics. There's a faster decline in the beta cell function, about 20 to 35% per year in teens compared to 7 to 11% per year in adults, despite all the aggressive medical therapy. Additionally, they usually require insulin earlier and about 6% of adolescents present in diabetic ketoacidosis at the diagnosis, where there's severe insulin deficiency at the outset. There's an accelerated rate of development of complications. There's about 6% albuminuria within 5 years of diagnosis, and end-stage renal disease in about 2.3% by 10 years after diagnosis. Microvascular changes such as retinopathy also appear earlier. There was reduction of brain volume with microstructural changes in the white matter and decreased cognitive function, which have also been reported. The economic burden is also not to be underestimated. So about more than $14 billion per year are spent on overweight associated costs such as emergency room visits, outpatient clinic visits, and prescription costs. And it's estimated that if all the 12.7 million US children with obesity become obese adults, the individual cost would probably be well over $90,000, with a lifetime societal cost over $1 trillion. Until the end of the lecture, I will be talking about the management of obesity. Obviously, before management and treatment, one would think prevention. There are thoughts on public health interventions that would help with preventing obesity, such as imposing taxes on sugar-sweetened beverages, calorie labeling on restaurant menus, implementing nutrition standards for food in schools, and a lot of other awareness programs. It is unfortunate that we have very little success in preventing obesity. Treatment. We do have limited treatment options. Lifestyle modification is the backbone of treatment for patients or for children with obesity. Regulation of the diet in terms of quality, carb and fat content, and additionally quantity control, daily exercise, all those are interventions that are the backbone of the management of obesity in children. Pharmacotherapy is a useful adjunct when patients with obesity are unable to achieve the above-mentioned lifestyle modification or any benefit from lifestyle modification. And lastly, there are surgical procedures that are implemented to try to treat the severely obese. Individuals are advised to work with a dietitian, and calorie restriction is essential. Low-carb diets, high-protein diets are usually implemented, and the low glycemic index diets are usually associated with an improvement in hemoglobin A1C values in these children. Exercise, we recommend moderately vigorous aerobic exercise. The duration, the recommended duration really depends on the age of the child. It's usually associated with improvement in physical health, something such as the blood pressure, mental health, such as anxiety or depression. And people who report that they have little time to exercise are usually encouraged to engage in multiple brief bouts of exercise or activity, something like 10 minutes every day. Use the elevator. Do not use the elevator, use the stairs instead. Try to increase your activity on a regular small bouts rather than a long exercise session. But remember, physical activity on its own only produces some little short-term weight loss if it's not combined with calorie restriction. You want to set the goal and identify any specific eating activity or cognitive or emotional factors that actually contribute to the individual's obesity and start working on it. You want to also record the progress, and this allows the caregiver to try to gauge and recommend further changes. And of course, reduction in screen time is highly recommended here. Lifestyle modification is the first line and has to be with every line of intervention, but unfortunately, on its own, rarely leads to meaningful weight loss, especially in the severely obese adolescent. Now, failure of lifestyle modification may be an indication for pharmacotherapy. And data from trials of currently approved anti-obesity drugs suggests weight loss ranging from 3 to 9% compared to placebo at a year. And the good news is that this is usually associated with improved glycemic control in these children. However, there's limited evidence for a sustained weight loss beyond 1 year of the use of pharmacotherapy. We don't have a lot of safety and efficacy data in children, and we don't have efficacy or safety data in post-bariatric surgery patients. There's inadequate inclusion of racial and ethnic minorities in most of those studies. They have not demonstrated a reduction in major adverse cardiovascular events, and there's a high dropout rate in clinical trials, and this limits the generalization of the findings to clinical practice. And last but not least, there's always a cost burden and a limited healthcare coverage for pharmacotherapy in obesity, with a negative perception especially from physicians, which limits the utilization of pharmacotherapy in the management of obesity. Some of the drugs used for the management of obesity include metformin, which is also a drug that's well known to be used in the management of type 2 diabetes. There's about a dozen randomized control studies that show that metformin provides a statistically significant but very modest reduction in the body mass index, especially when combined with lifestyle modification over the short term. We all know that metformin is associated with GI adverse effects, which causes dropouts in many patients taking metformin. Orlistat is probably the only approved, or at some point was the only approved medication for the treatment of obesity in over 12-year-olds. Efficacy is really modest, and the 1 year placebo subtracted change in the body mass index is less than 1 kilogram per meter squared, which makes us question the efficacy of such a drug. Another player that's more commonly used in the adult population is phentermine, which is a short-term appetite suppressant, and it's a amphetamine-like prescription medication. Data suggests that the short-term use of phentermine, in addition to lifestyle modification, may enhance the weight loss in adolescents with obesity in the clinical setting. Liraglutide is another player that recently received FDA approval for pediatric obesity. This New England Journal of Medicine published clinical trial tested or enrolled participants between the ages of 12 and less than 18 with obesity that had a poor response to lifestyle modification alone. They implemented liraglutide 3 milligrams subcutaneous or placebo once daily for 56 weeks, almost a year, or about a year, followed by 26 weeks follow-up period. And the change of the body mass index from baseline and at the end of 56 weeks was tested. Unfortunately, there were some gastrointestinal adverse events in the liraglutide group compared to the placebo, and after discontinuation, a greater increase in the body mass index standard deviation score was observed in the liraglutide group compared to the placebo. However, the study group concluded that the use of liraglutide, in addition to lifestyle modification, led to a significant reduction in the body mass index at around 56 weeks. Again, good results, however, rebound after discontinuation of the drug. And now I'm going to switch gears to talk a little bit about bariatric surgical procedures. And we have 3 common types: the sleeve gastrectomy, the Roux-en-Y gastric bypass, and the laparoscopic adjustable gastric banding. Between 2011 and 2016, there has been a shift from gastric banding to Roux-en-Y to sleeve gastrectomy, the less complex with fewer post-operative complication procedure. About 216,000 procedures were performed in 2016 in the United States. Over half of those were sleeve gastrectomies compared to 19% Roux-en-Y procedures and 3% gastric banding procedures. The mechanism of action, or the mechanism how bariatric surgical procedures help, is incompletely understood. But we know there's a reduced volume or calories of food consumed, especially in the banding or the sleeve gastrectomy. There's diversion of absorbing surface area in the Roux-en-Y. There's increased stimulation of insulin secretion via incretin mediators such as the GLP-1 and peptide YY. There's increased secretion of the fibroblast growth factor 19, which regulates bile acid synthesis with effects on glucose and lipid metabolism. There's also decreased ghrelin secretion, a hormone predominantly produced in the stomach that normally signals hunger to the brain and increases appetite. Outcomes are usually durable treatment for obesity. There's usually remission of comorbid conditions, and this is superior to medical treatment. There's improved quality of life, and it's probably a more cost-effective, although initially it incurs more substantial costs, but over the long term it becomes more cost-effective. I'm going to share a couple of studies that review the long-term outcomes of bariatric surgery in the pediatric population. So this study is a prospective study of an about 8-year duration. 58 patients received various bariatric surgical procedures of an average age of 17 years, and their average body mass index was about 58.5 kilograms per meter squared. The study shows at the end of the 8 years, the BMI reduction was about 29% and almost 90% remission rates of type 2 diabetes. 2/3 of the patients with hypertension had remission, and dyslipidemia remission was in about half the cases. This is another study of 3-year duration, but more patients were recruited here, about 228 patients. Average age was 17 years. Body mass index average was 53 kilograms per meter squared. Again, a body mass index reduction of about 28%. Remission rates were also great. Type 2 diabetes remission was 95%. Prediabetes remission was 76%. Hypertension remission, 74%. Dyslipidemia, 66%. And renal impairment remission, 86%. This one is the laparoscopic Roux-en-Y gastric bypass in the adolescent population with severe obesity, 5-year study. 81 patients, average age also close, about 16 and a half years, a body mass index average of close to 45 kilograms per meter squared. Duration was 5 years, and the body mass index reduction was also about 29%. Again, 100% of the patients who had type 2 diabetes were cured here. There was remission, about 86% in prediabetes, 92% of the hypertension, and 83% of the dyslipidemia. This is another study, again, 5-year outcomes in adolescents compared to adults. So prevalence of diabetes in adolescents was 14%, and it was reduced to about 2%. And in adults, was 31%, and it was reduced to 12%. Medication for diabetes in adolescents, 88%, and then none of them at the end required medication. And in adults, 79% were on medication, and at the end was about 26%. So their conclusion was that adolescents were more likely to achieve a hemoglobin A1C of in the non-diabetic range, less than 6.5%, irrespective of medication use after the 5 years. Very significant results. Compared to patients with diabetes at baseline, 86% of adolescents and 53% of adults no longer had a hemoglobin A1C in the diabetic range after the study was complete. Now, this is a study for cost effectiveness of bariatric surgery, where they compared no surgery to bariatric surgery, and they evaluated outcomes, whether it's quality adjusted life years or total cost in US dollars, and they made a conclusion that there are substantial initial costs and morbidity, but if assessed over a time period of 5 years, bariatric surgery in the severely obese adolescent would be cost effective. There's also obviously more long-term outcome studies that need to confirm this. Of course, bariatric surgical procedures come with risk. There's a lifelong need to follow up nutritional deficiencies such as vitamin B12, folic acid, iron, vitamin D, and vitamin D deficiencies. Although rare, possible complications include leakage and anastomosis, sepsis, bleeding, and mortality is comparable to common elective general surgery. Now, who do you want to offer the bariatric surgical procedure to? The American Association of Clinical Endocrinology Clinical Practice Guidelines suggests a body mass index of greater than or equal to 40 kilograms per meter squared without coexisting medical problems, or individuals with a body mass index of greater than or equal to 35 kilograms per meter squared plus one or more comorbid condition, or those with a body mass index greater than or equal to 30 kilograms per meter squared with poorly controlled diabetes. The Endocrine Society Clinical Practice Guidelines suggests bariatric surgery for individuals 10 or 4 to 5 pubertal development who have reached their adult height or are near their final adult height, who have a body mass index greater than 40 kilograms per meter squared, or a body mass index greater than 35 kilograms per meter squared with significant extreme comorbid conditions. Extreme obesity and comorbidities persist despite compliance with a formal program for lifestyle modification with or without pharmacotherapy is another indication. The Endocrine Society Clinical Practice Guidelines are against bariatric surgery in pre-adolescent children, pregnant or breastfeeding adolescents, and those planning to become pregnant within 2 years of surgery, and in those who have not mastered the principles of healthy dietary and activity habits, and those with substance abuse, eating disorders, or untreated psychiatric disorders. In summary, obesity is common and a threat to our youth. Treatment helps reduce morbidity, avoid stigma, bullying, and isolation that are often associated with obesity. As evidence supporting the safety and efficacy of pharmacotherapy continues to accrue for the adolescent population, it will likely become a more accepted and commonly used therapeutic option. Bariatric surgery is likely effective, durable, safe, and cost-effective intervention for weight loss, resolution, and prevention of disease. However, it's underutilized. We need more long-term data to be able to recommend bariatric surgery. Thank you for your time.
Thank you very much, Professor Ahmed Khattab, for your illustrative presentation on childhood obesity and adolescent obesity. Thank you very much indeed. And now we will go to Colin Clark. Her talk will be about important concept in educating patients on insulin pump. Colin is a registered nurse and she's certified diabetes educator in USA.